Here is our roadmap. We're starting with chronic and vascular ulcers. Then we'll move into staging pressure injuries. After that, we'll look at surgical scar prevention, contrasting hypertrophic scars versus keloids, and finish up with advanced scar management protocols. Let's get to it.
Section 1. Chronic and vascular ulcers, and the stalled inflammatory phase.
So imagine a wound that has essentially hit a biological brick wall. What you're seeing centrally is slough. It's this layer of necrotic debris that's actively harboring a persistent infection. But the real issue? It's the fibrotic margin completely surrounding it. The tissue has literally walled itself off, completely stalling out the normal repair mechanism.
Now, what's actually causing these leg ulcers to begin with? Well, vascular issues, whether that's venous, arterial, or a mix of both, are definitely the most common culprits. But we absolutely cannot stop our differential diagnosis there. We have to consider metabolic diseases, things like diabetes, gout, or calcifionosis. We also need to look for autoimmune conditions and localized infections because pinning down that underlying root cause dictates our entire game plan for getting the wound unstalled.
And this brings us to an absolutely crucial point. Long-standing ulcers carry a high-stakes risk of malignancy. It demands strict vigilance. If you've got an ulcer that is just completely unresponsive to a meticulous, proper dressing regimen, you have to suspect a Marjolin's ulcer. At this point, it's not just a wound anymore. It's a highly aggressive squamous cell carcinoma arising directly within that chronic ulcer or an old burn scar. The clinical rule here is absolute. You must biopsy it to rule this out. No exceptions.
Moving right along to Section 2, Staging Pressure Injuries and Anatomical Depth.
Notice these key anatomical danger zones: the ischium, greater trochanter, sacrum, heel, malleolus, and occiput. When localized pressure cuts off the blood supply over these specific bony prominences, the tissue simply dies. But the good news here is that this pathology is highly preventable. If we use established risk scales like the Braden, Waterlow, or Norton scales, do our routine skin checks, and actually commit to repositioning the patient every 2 to 4 hours, we can stop these injuries before they even start.
To systematically categorize the progressive anatomical depth of this tissue loss, we rely on the NPIAP system. It's a pretty clear progression. Stage 1 starts right at the surface with non-blanchable erythema, though the skin is still completely intact. By stage 2, you've got partial thickness loss, meaning the dermis is exposed. Stage 3 breaches into full thickness loss where you can actually see the subcutaneous fat. And stage 4, that's severe. We're talking full thickness loss extending all the way down to exposed or even palpable fascia, muscle, tendon, or bone. And of course, if the wound is so heavily covered in necrotic slough or eschar that you literally can't see the base, it's classified as unstageable.
You also really need to keep an eye out for deep tissue injuries. These present with a very distinct, persistent discoloration, usually deep red, maroon, or purple. Even if the skin looks completely intact on the surface, if that color doesn't blanch when pressed, it's a massive warning sign. It tells us that severe, deep damage is happening right below the surface.
Now, here is a massive surgical red flag when it comes to managing these injuries. Do not use primary closure. Primary closure and basic skin grafts have extremely high failure rates here. You can't just pull the edges of a pressure ulcer together and sew it up. Instead, surgical management requires large fasciocutaneous or musculocutaneous flaps. And the genius of this surgical design is that they have to be designed defensively. You plan the flaps so that if the pressure ulcer ever recurs down the line, you can actually advance that exact same flap further to cover the new defect.
All right, Section 3, the principles of meticulous scar prevention.
Once we are in the OR, precise anatomical alignment is literally everything. I mean, even a 1 millimeter error at the lip vermilion border is going to be highly visible. So, surgical planning is step 1. Incisions have to be perfectly aligned within the relaxed skin tension lines and never placed directly across flexion creases. Also, a quick aside, if you don't scrub initial wounds thoroughly, you're risking a permanent, dirt-ingrained, tattooed scar. For the actual closure, we follow a strict sequential protocol. You close the deep fascial layers first, like scarpus fascia. Then you place absorbable deep dermal sutures. Why? Because you need to take that physical tension off the surface of the skin. Finally, you run subcuticular monofilament sutures right at the top to prevent those classic indented track marks.
And timing is everything when it comes to taking those sutures out. For the face, they need to come out fast, by day 5, to guarantee a pristine cosmetic result. But the lower limb is a totally different story. It's under much higher tension and slower to heal, so those sutures need to stay in for about 10 to 14 days.
Okay, let's move into Section 4, contrasting hypertrophic scars versus keloids.
Structurally and behaviorally, these two are completely different beasts. Hypertrophic scars have parallel collagen, they stay strictly inside the boundaries of the original wound, and they actually tend to regress over time. We usually see them in areas of high physical tension or from deep burns. Keloids, on the other hand, they are characterized by completely disorganized collagen. They aggressively spread way beyond the original wound boundaries, they absolutely do not regress naturally, and they have very strong links to genetics and darker skin types.
Which brings us to our final section, advanced scar management protocols.
Before we escalate to the heavy-duty interventions, both hypertrophic and keloid scars share some foundational, first-line, non-invasive therapies. The international protocol dictates starting right here: silicone gel or sheeting, tension relief taping, really diligent hydration of the tissue, and strict UV protection. These are your universal baseline defenses.
But if that scar remains red and raised, we follow a strict step-by-step escalation. For early, immature hypertrophic scars, we push those preventative algorithms: silicone, hypoallergenic paper tape, maybe some onion extract cream. If we hit the 2-month mark and it's still unresolved, we step up to linear treatments like pulsed dye laser or PDL and fractional laser therapy. This is also when we introduce monthly intralesional corticosteroid injections, specifically triamcinolone acetonide. Precision really matters here. We use 2.5 to 20 milligrams per milliliter for the face, but we bump that up to a much stronger 20 to 40 milligrams per milliliter for the body. And for widespread burn scars, that completely escalates to specialty burn units using intense pressure garments or full surgical excision.
Keloids demand a totally different, often much more aggressive pharmacological approach. Sure, minor keloids might respond to basic intralesional steroids, silicone, or cryotherapy. But for major, high-risk keloids, the algorithm requires a highly targeted combined pharmacological assault. We're talking about using 5-fluorouracil, or 5-FU, directly alongside those intralesional corticosteroids.
And here is the golden rule for keloids: you can never, ever just surgically excise them. Excision alone carries a massive recurrence risk, and honestly, they often come back worse than before. It absolutely must be paired with immediate post-operative adjuvant therapies. That can mean local radiotherapy, silicone sheets, continuous steroid injections, or specific alternative topical and intralesional meds like bleomycin, mitomycin C, or imiquimod. I really hope this deep dive has clarified the exact mechanisms behind tissue repair and clinical intervention for you. Seeing how these meticulously layered clinical strategies can prevent permanent damage is just fascinating. So as we wrap up this explainer, I want to leave you with a thought. If surgical precision dictates the baseline for tissue repair today, how might the continued evolution of these advanced pharmacological adjuvant therapies completely rewrite our approach to high-risk scarring in the future? Keep learning, and thanks for joining.